So I'm just going to share with you some mysteries of the neck. And this was a presentation on neck femur and neck radius, but I'll stick to neck radius here. This is the first case. This is a fracture through the neck of the radius in a 7-year or 8-year-old boy. So let me put the question to everybody in the audience. Is this acceptable? Those who agree, raise your hands. No, no, no. Close reduction and cast? Yes? Okay. Open reduction, anyone? Open reduction? Yes? And percutaneous techniques to get reduction? All right. A lot of people want to do percutaneous technique. So this child was treated with open reduction, and this is the outcome. You can see that there is cross union and synostosis with a completely restricted pronosupination. This is what was done, which was a disaster. So something to take home, that please don't do these kinds of things. Okay, let's come to the next case. A 9-year-old girl. Ashish, how would you treat this? Acceptable, not acceptable?
Close reduction.
Close reduction. Samir?
Definitely closed, or it's a 9-year-old, right?
Yeah.
So looks acceptable that way, but
All
try
right.
to get it a little better. That's
All right. Ranjit?
I would try a percutaneous.
Percutaneous. Anil, senior person?
Closed.
Closed. All right. So this was treated in a plaster. Everybody agrees conservative. Okay, this is how it was, and this is how she came to me. So whether you open or you close, the purpose of this presentation is to tell you that please look at a fracture of the neck of the radius more critically than you think, right? Because open reduction is a recipe for disaster. You have contributed to the damage. But even in a closed reduction, if there is a concomitant intraosseous injury on the ulnar side and the hematoma ossifies, you can still end up with a cross union. So this is a girl who came to me with this position where she had completely restricted pronosupination and there was a valgus deformity which she was concerned about. And I was wondering what should be offered at that time. And then with appropriate counseling, we decided this is a post-traumatic situation and it's quiescent, so I must attempt resection. So question was, should we wait and watch? How many for wait and watch? Because she has full range of motion. Okay, most of you. Radial head excision, replacement. Adult trauma surgeons replace the head? No. Derotation osteotomy because she has no pronosupination. Samir? No. Derotation osteotomy?
Injury for one side, I don't think so it's required.
Unilateral. But
it's unilateral. That's
okay, okay. Or excise the synostosis. Pankaj was here. Where is Jindal? No. Okay. Right. So I decided that this is not a congenital synostosis. This is a post-traumatic synostosis and it behaves differently. So we did some advanced imaging to quantify the amount of fusion mass and we found that it was quite reasonable, about 1 centimeter. And I could approach it through the posterior approach. So through the posterior approach, I went and isolated the radial head and dissected the synostosis and separated the synostosis and separated the radius from the ulna. And the gap that I created, as you can see in the extreme right, that gap I filled it up with a fat graft, right? Some inert material so that interposition happens and there is no cross union again. And that was the fat graft harvested from the triceps area, and that fat graft was put in between that, and I took a suture so that it doesn't wash off when you release the tourniquet. And that is how it was put there. And on table you can see there was reasonable restoration of rotation. You can see that raw area at the radial neck. That was the pronosupination which was completely restored, right? And okay. That was the range of motion. You can see that raw area and not so raw area as the radial head moves. This is the post-operative X-ray with the gap restored. That's the function at follow-up, 2 months, with aggressive active physiotherapy to begin with. And I don't know, the video is there, but should work. Perfect. So she got back her range of motion. And Everybody was happy. So just to give you this message that there is a classification for pediatric cross unions or synostosis which may be distal, diaphyseal or proximal. And they behave differently from congenital synostosis, and resection with fat grafting does work. So please keep that in mind. Thank you very much.